Okay, well, why don't we get started this morning? Good morning, everyone. If you're in the Western Hemisphere, or good evening if you're on the other side of the world. Thank you all for joining. This is a webinar on a cardiac conversation about biventricular repair options for patients with hypoplastic left heart and borderline left heart. And we hope today to kind of share some of our knowledge and information and answer some questions that you might have. We're going to start off today by just sort of having a conversation, asking some questions of our panelists. You're welcome to start jotting down some questions in the Q&A, but we're going to address all the questions at the end of the session, if that's okay. But feel free to enter them in, and then we'll make sure that we get to them at the end of the webinar. And with that, why don't we start with introductions? And I'm going to ask Dr. Baruchim to introduce herself.
Thank you so much, Dr. Ramani. My name is Rebecca Baruchim. I'm a cardiologist, and I primarily am a cardiac imager here at Boston Children's Hospital. So I take care of patients, particularly many patients with complex biventricular repair type circulations. And I also do cardiac MRI, cardiac CT, echocardiography. So my background is in imaging. And then I'm also the medical director of the complex biventricular repair program.
Great, thank you very much. Naomi, can you please introduce yourself?
Thanks, Dr. Ramani. My name is Naomi Curley. I'm one of the surgical physician assistants here at Boston Children's. I help both in the ICU and the OR, so I'm kind of overall seeing patient care from start to finish. And now I'm helping with the second opinion program at Boston Children's Biventricular program.
Great, thanks, Naomi. And Naomi is really the key center point for our program and keeping everything together. So thank you for doing that. My name is Ram Imani. I'm a cardiac surgeon here at Boston Children's Hospital. And for a long time, I've been really interested in sort of thinking about novel ways to take care of patients with hypoplastic left heart and borderline left heart. So it's probably been beginning in the early 2000s that we started thinking about these novel treatments. And we're really excited to share some of our information with you today and hear your questions. So let's get started. I wanted to just start off by asking Dr. Baruchim to give us just a little bit of a brief overview of the borderline left heart and kind of, what is a borderline left heart and what are the different forms of hypoplastic left heart that we're thinking about? And so can you share with us your thoughts on this, Dr. Baruchim?
Thank you so much. So I'm going to actually, if it's okay, I'm going to start by sharing some slides that I've prepared for today. And just to get us started. So can you guys see my slide deck?
Yes, great, thanks.
Okay. This is just a very brief overview, just to make sure that we're all starting out on the same page. And so I just wanted to begin by talking about the function of the heart and the lungs. And basically, the heart and the lungs, their function is to oxygenate the blood and to pump that oxygenated blood around the body. And so that's kind of the way we think about congenital heart disease, is sort of this interaction between the heart and the lungs and sort of trying to get blood oxygenated and get that circulating around our body. So when we look at the heart, the typical heart has 4 chambers and 4 valves, and that's just really important to kind of understand the basic anatomy of the typical heart and how it's formed. And then when we look at the specifics of the heart, there's the right heart and the left heart. So the right heart typically takes the low oxygen blood and pumps that blood to the lungs. And then the left side of the heart takes the high oxygen blood and pumps that to the body. And so we have ventricles and valves on each side of the heart. And I just want to emphasize that the ventricles are important because they have to be big enough to pump enough blood either to the lung or to the body. And then the valves are really important as well because they need to be able to open wide enough to allow the blood to move forward, and then they have to close to prevent the blood from swishing backwards. So for example, if you have just a heart with muscle and there's no, valves are not working, the blood would just sort of swish back and forth. So the valves are really important to promote forward flow of the blood. And so this webinar is really about the different forms of hypoplastic left heart and talking about ways that we can get patients to a 2 ventricle or 1.5 ventricle type of circulation. So we're really going to focus on things like HLHS, which is a hypoplastic left ventricle, but no ventricular septal defect or no hole between the ventricles. We're also going to talk about, this also refers to patients with AV canal or AV septal defects that have a small left ventricle. And then we're also talking about patients with certain types of outflow tract abnormalities, such as transposition of the great arteries or double outlet right ventricle that's associated with a small left ventricle. And really what we want to emphasize here in our program is that not every patient has to have a Fontan operation, that every patient is unique in terms of the way their heart was put together. And there are many cases in which we're able to use both ventricles in the circulation. So again, the program goals of the complex biventricular repair program are to make the best individualized decision about each patient, based on their specific cardiac anatomy. And then also to think about different types of biventricular repair options so that patients can avoid a Fontan circulation.
Great. Well, that's great, Dr. Burkham. But let me ask you something. Why should we consider a biventricular repair as opposed to single ventricle management? And what do you see as the benefits? Why are we interested in this?
Yeah, so we know that the Fontan operation was really a major breakthrough in congenital cardiology because it has allowed for patients to survive much longer than they would have if the Fontan was not sort of invented. However, we know that there are long-term complications of the Fontan circulation, and that really rests on the fact that the blue blood or the low oxygen blood, the way it arrives to the lungs with a Fontan circulation is there's no pump. It's just the blood is sort of passively flowing into the lungs. So the veins tend to be at higher pressure. And that high venous pressure can cause pressure in the organ systems of the body. So there are multiple organs that can be affected by these high venous pressures. So the ones that we think about the most are the liver. So Fontan circulations can cause progressive disease and scarring of the liver. And then also the lymphatic system, which is the system that kind of helps to circulate lymphatic fluid, which is the fluid that we use to fight infections and carry fat around our body. So those things can develop problems with the Fontan circulation over time. And so really the goal of a biventricular circulation is to avoid some of these long-term complications of the Fontan circulation.
Yeah, I've certainly seen patients, not every patient with a Fontan gets complications, but I've certainly seen patients after a Fontan get in. I think one of the things that's a concern is we can't really predict who will or will not develop complications of the Fontan. And so in my mind, that's one of the reasons why I've been really thinking about ways to pursue it. So how do we determine, if a child is potentially a candidate for a strategy to avoid the Fontan? How do you do that?
Yeah, so I think about it in 2 major categories. So the first one, so the 2 major categories that I think about whether or not someone's a candidate is, one, is it anatomically feasible, meaning is the heart set up in a way that the pathways can be like routed correctly to get the blue blood through a ventricle and out to the lungs, and the red blood through a ventricle and out to the body. And then the second feature that I think is really important is whether it's hemodynamically feasible, meaning if the routing is we're able to sort of get the blood routed in the correct direction, is the blood flow going to be adequate so that the child will come out of the surgery having good cardiac output or a good amount of flow flowing through their heart? And so those are kind of the 2 main features that I use or I think about. And so we use like all forms of imaging as well as catheterization and different modalities of understanding what the heart currently looks like and what it's currently doing to sort of get an impression of whether a child is going to do well after a biventricular type of surgery.
Okay, so I have a child with with borderline heart or maybe the doctors have told me that it's a single ventricle, but I want to know if my child may be a candidate for a biventricular repair. What do we need to do? What are the what all needs to be kind of put forward?
Yeah, so I would I would look at different testing. So, one of the main tests that we use is cardiac MRI in a lot of our patients, sometimes cardiac CT. And what I would look for, and also we use echocardiography and cardiac catheterization, but what I want to look for is what is the size of the ventricle? So if we're talking about the small left ventricle, what is the actual size relative to the size of your child? So we have some criteria for what is a ventricle that is just too small for a biventricular type of circulation. And then we have criteria for what we consider borderline, and then kind of normal size. And so I would look at the size of the ventricle. I would also look at the size and the function as well as the features of the valves that are both coming into the ventricle and leaving the ventricle. And I would look at the pathways just to sort of understand whether things could be routed correctly. And then finally, the other thing we pay a lot of attention to is the function of the ventricle, how well it's squeezing. And just to get an impression, because for a lot of these kids with small left ventricles, with certain types of surgeries, whether it's a recruitment procedure that allows for the ventricle to grow, or just a full biventricular repair, which also allows the ventricle to grow, sometimes we can get pretty good growth of the left ventricle to a point where it's able to function in a relatively normal capacity.
So, do we need to get MRI and everything first, or Naomi, maybe you can tell us a little bit about, if we're just starting to explore this. How do we understand if a child may be a candidate? What's our process for sort of thinking about that?
Yeah, so the first part is we're really just starting with the basics. We're starting with your cardiology notes, we're starting with your old surgical notes, and then we're also trying to get any type of imaging, such as Dr. Rukem talked about. If you have an echocardiogram, if you have a cardiac CT, those are at least a starting point that we can kind of assess the anatomy. And also those reports are really important, especially if they've had a cardiac catheterization, to see those hemodynamics, also get a sense of the physiology. We'll start with these, and then I'll also usually give you a call to see, are there any other additional records that you might have that you didn't know were important? So we try to collect all those before we review your case so that we may be a starting point that for additional imaging or to give you a good sense of if they are a candidate for surgery.
What happens next? Maybe you can talk a little bit about the discussion process and how that happens.
Yeah, so actually, after we've collected all your images, all your records, and I've spoken with you, and speaking with you too is really important to see if there are other conditions that your child has and to get an overall sense of how they're doing now in time. After that, we kind of comprehensively review all of this information at a conference together. That conference usually includes 2 surgeons and at least 2 to 3 cardiologists there that all kind of look at all the imaging, all the data that we've gathered to see what are the best options possible.
It's also nowadays we've been using the 3-dimensional modeling, which is a really cool technology that allows us to take any imaging, usually an MRI and CT, and turn it into a 3-dimensional model that can be used to help with analysis that I find pretty helpful. Maybe I can just kind of talk a little bit about what exactly is a biventricular repair and touch on some of the technical points. And to do that, I'm just gonna share my screen to talk a little bit about what a staging procedure is. Now, this video is available on YouTube for anybody that's interested in looking at it. And so what I want to just share is this part that sort of talks a little bit about what the first stage is. So no matter which way you go, we don't tend to do ventricular recruitment at the time of a newborn baby. So this is what the Norwood procedure is, where you're connecting up all of the blood flow from the left ventricle and the right ventricle together. And then the next step is really where we start to get the recruitment process together. And this is really at about 4 to 6 months of age. If you've had the stage 1, if you've had a Norwood, we had a hybrid stage 1 during the neonatal time frame, this is the time, 4 to 6 months, sometimes up to a year, where we're starting to think about recruiting the ventricle. So what happens at that time frame? We want to open up that mitral valve, got to get some good inflow into that left ventricle. Open up that mitral valve to get the inflow. The next thing we do is open up the aortic valve, get some good outflow. Without good inflow and outflow, you can't do it. Then we remove this endocardial fibroelastosis. This is present in the patients with hypoplastic left heart syndrome. And that allows things to sort of grow together. We might do a Glenn. Sometimes we upsize the shunt. If we're gonna do that, we're gonna leave some flow going forward by leaving the extra blood flow. And then we're gonna restrict the atrial septum, which means we're gonna force some of that blood flow into the left ventricle to get things to grow. Now, what's really important to realize is that during this process, while we're recruiting, what we're doing is we're forcing more flow into the left side of the heart to get it to grow, but we're not burning our bridges for a Fontan. If, for whatever reason, the left side of the heart doesn't grow, we want to still be able to go to a Fontan. I think that's really important, is that we do not lose our candidacy, but we try to see if the ventricle can respond to whatever maneuvers that we perform. And if that ventricle grows over time, from the flow phenomenon, we can tell that. We usually get an MRI and get a better sense of how the ventricle grows. And once the ventricle is grown, if we think that everything looks favorable, we can just reverse the circulation, which means that we can take down that connection between the aorta and the pulmonary artery, reconnecting things up the way that they should, and then we're back to somewhat of a normal circulation. So this is in the most favorable of cases, we're able to do now what's known as a biventricular conversion after we've done a period of time of ventricular recruitment. And so that is, I think that is one important point. Again, this particular staged recruitment can be done for many patients with a borderline left heart, where we're just like, you know what, the left ventricle is not quite ready yet, but I really don't want to go down the Fontan route. Let's give it a try. The earlier we know about the child, the better, because I like to start the recruitment process during infancy, less than a year of age, if we can, and trying to really think about this as a continuity, as a sequence, and how we gradually get there. We're trying to load the ventricles really slowly. We're not trying to all of a sudden put a load on the heart. Again, I'm not trying to give you all of the procedures that we do here, just to give you a sense of how we think about things from a surgical standpoint, and how we're thinking about the heart, how we're thinking about growing the heart. Another example of a procedure is, okay, so we've gotten some growth of the left ventricle, but it's not good enough to be a systemic ventricle. Is there still a way to avoid the Fontan? Well, there is another solution that we've sort of come up with in the past several years, in which we use the left ventricle as a pumping chamber. And I want to just share a little bit of that. Some of you may have seen this. Again, this is available on YouTube. Feel free to check it out. This is just kind of giving a sense of what we do. And so here we have a left ventricle that's not quite ready for prime time. And so we are going to try to use it as a pulmonary ventricle. And the way we do that is we actually reroute the blood flow from the venous return, from the SVC, superior vena cava, and the inferior vena cava. Blood coming back from the body is going to be rerouted towards that left ventricle. Okay, and so then next, what we're going to do is we are going to now redirect some of the outflows. So now we're going to take the outflows and we're going to switch them around, so that the outflow from the left ventricle goes to the lungs, and the outflow from the right ventricle is going out to the body. And this is known as a reverse double switch operation. A double switch because you're switching the inflows to the ventricle and the outflows to the ventricles together. And this allows us to now have that right ventricle still pump to the body, but don't give up on that left ventricle. It's going to do some work and let it pump to the lungs. And so this is a strategy that can be used in some situations. And again, it's as Dr. Baruchim mentioned earlier, it's really, we really try to personalize the surgical approaches to each child's anatomy at presentation, as well as how that ventricle responds over time. So that's just to give you a little bit of a flavor. We're now also in some situations taking down Fontan for patients who have a circulation that may be amenable to avoiding the Fontan, and we're continuing to develop that procedure.
So Dr. Armani, there are two questions in the chat that I just wanted to pick up on. So the first one is, in general, how long does recruitment stage last for an infant being born at Brigham and women for immediate care at BCH? I'm just wondering if you could just touch on, when do you start the recruitment process? Is it during infancy or is it a little bit later? And then also just sort of like, how long do you wait after recruitment to reevaluate the ventricle?
That's a great question. So when a child is born, there might be a situation in which we try to go right to a biventricular repair. And that's a complex decision. Dr. Baruchim and I frequently sit down and take a look at the imaging and try to make that decision. If there's any question, I would rather not do a high-risk biventricular repair, but try to do the staged recruitment process. And so we make that decision based upon the echo. Let's say we've decided to do a stage 1 or a PA band in the neonatal time frame. The recruitment process starts generally less than a year of age, generally around 4 to 6 months of age when we're coming back for the Glen. At that time, the second stage, that's when we start to think about recruitment. It usually takes about a year, 10 months to a year, for a ventricle to show how much it's going to respond to whatever recruitment procedures we've done. So then we repeat the imaging at that point and say, okay, how do we look? Can we go biventricular? Do we need to do more recruitment? Or do we need to do some sort of a reverse double switch or reverse 1.5?
Thank you so much. And then the other question that I can probably answer that's in the chat is, what are your criteria for sufficient left ventricular recruitment to not go down the Fontan pathway? So that's a really good question. We have kind of some cutoff criteria for what a normal size left ventricle is and normal left ventricular stroke volume, and we tend to look at that. There are some ventricles that are very clearly, we're able to go down a biventricular repair pathway. And, typically those ventricles that have a left ventricular end diastolic volume index over 50 mLs per meter squared. And then there's sort of some of those ventricles that are in the more borderline, they have a more borderline size. And we basically look at the size relative to their body size to sort of make those determinations. Again, it has to do with size as well as how much blood the ventricle is actually pumping, and also the size of the valves. So it's a little bit difficult to kind of speak to exactly what criteria, because each patient is so unique and individual. And this kind of gets back to the fact that we oftentimes really just need to review the data and kind of provide very individualized recommendations and treatment plans for each patient. Because it's some of it is about the size of the ventricle. Some of it is about whether or not there's endocardial fibroelastosis or not. Some of it's about the size of the valves, what the ejection fraction of the ventricle is. So there's so many different things that go into our decision-making process that it's very hard for me to sort of just sit and kind of spit out everything that we look at, because it's sort of, we're looking at everything in combination.
Yeah, I certainly agree. I mean, I feel like the more options you have, the more it becomes important to say who's most appropriate for which treatment. And I think that's really a combined decision. I find that in our complex biventricular repair conference, we have some 20 people that are sitting together and looking at the imaging, and I think the conversations that we have there in assessing the MRIs and the catheterization data and the response, It's quite nuanced, and I agree with you. I feel like you know no two children are alike in terms of how they respond and their anatomy. And in a way, it's great that we have different options, but it means that we have to make much more nuanced decision making when we have a patient like that. There was another question about about transposition and whether it's I suppose the reverse double switch, is it better than a Fontan for the future? And I think there are a lot of there's a lot that needs to be done in terms of really looking at the long-term outcomes of a lot of the strategies that we're pursuing. Again, we've really started exploring and implementing a lot of these strategies since the early 2000s. And so some of our patients are in their 20s, and we're seeing some patients that have really good outcomes, but we really need long-term data to compare to the Fontan. I think that there's some data that we have now to suggest that we're able to avoid the liver dysfunction that happens commonly with the with Fontan. And so I think that's encouraging, and so this is something we need to keep a close eye on, which sort of brings me to the next question I have for both of you, Dr. Brukim and Naomi, and it's about a little bit about the follow-up and support after each stage or as a part of this process. How do you think about the follow-up care and what is necessary? Maybe I'll start with you, Dr. Brukim, and then Naomi.
Yes, sure. Thank you. So first of all, when a child comes here for surgery, we try to provide some level of continuity. So the primary cardiologist that's following the child will kind of check in periodically and sort of be a point person for the family. So we're kind of there along the whole process. And then after a child has been discharged from the hospital, we will sometimes see them in clinic, like maybe once, just to make sure they're kind of ready for going back home. But then once the child has gone back home, we usually work with the primary cardiologist at home and try to kind of coordinate care so that we're still involved in the care of the child, but we recommend that everybody still has their like home cardiologist and they get their local follow-up. We also have begun to implement a survey that we are sending out to our families to sort of understand what the follow-up is like for patients. So we're very closely trying to track quality of life and some other kind of really what we think are very important factors in understanding our group of patients. And this is also a nice way to stay in touch with us because we screen the results of these surveys kind of going forward and just try to stay in touch. So families can reach us, after they've had surgery and gone back home, they can reach us through different mechanisms. We have kind of our patient portal. We obviously communicate with the local cardiologists relatively frequently, and then through the surveys as well. These are ways that we can stay in touch.
Naomi, do you want to talk a little bit about how you sort of stay in touch with the families from the very beginning to after as well?
So from the very beginning, especially if you started as a second opinion, my hope is I'll meet you at that point in time with a phone call, even as we're just starting the process. If you do end up coming here for a surgical intervention, my hope is that I'll get to see you in the pre-op period, and then I'll also follow you in the ICU. I do also surgical care too, so I'll see you in all of those portions of your hospital stay. Once you're discharged, as Dr. Barucham said, if there's anything that comes up on the survey or if you have questions, I'm one of the people that will likely be reaching out to see, do you have concerns and how can I help? Even if that's working with your local cardiologist or getting in touch with Dr. Barucham or Amani if we need to do something while you're at home.
I think one of the things that I find is super important is that we really create a close connection, not only with their families, but also with their care providers back home. And a lot of cardiologists and cardiac surgeons are not really familiar with with some of the work that we've been doing and what is possible. And I think it's really important to not only share with them how we're approaching this, but to educate them on the outcomes. And I think there's a lot of data that is being generated. We have a lot of manuscripts, papers that we've published on the subject matter that we can share with you and with your care providers, just to kind of have that information be available. And we also welcome open discussions with your local team because we feel that it's important to really keep that connection.
If I can just, I have a 3D model pulled up, and I just want to go over a little bit of how we do our counseling related to these 3D models, because I think it's helpful. So some of our process is to get a very comprehensive evaluation of a child, and then we try to use these 3D models for family education. And I found that to be really helpful for families, just in terms of understanding what their child's anatomy is. So this is an example of a child with heterotaxy syndrome who also had a small left ventricle and had complex anatomy. So, things were not connected up the way that, in a very easy way to go for a biventricular circulation. So from this 3D model was generated from a cardiac MRI image, and it really has a lot of detailed information about the ventricles, the vessels, the aorta, and this child, you can see, actually has bilateral Glenn shunts here that have been placed. And then there are two ventricles. The orange one is the left ventricle, and the sort of purplish one is the right ventricle here. But this left ventricle was small for this child. And so the plan had been, the local plan had been for a Fontan operation. But what we have found in some research that we've done here at Boston Children's Hospital is that a biventricular repair option for children, particularly with heterotaxy syndrome and what we call right dominant AV canal defects, a biventricular repair option has higher survival than a Fontan operation. So we really have been trying to promote the biventricular repair type options for this population of kids. And so this child actually was unable to undergo a biventricular repair, which involved, complex baffling of some of the veins, as well as baffling of the left ventricle up to the aorta and the placement of a conduit from the right ventricle to the pulmonary artery. So it was complex surgery. And that's one thing that I just want to kind of emphasize, is that the biventricular repair is definitely a more complex surgical procedure to perform than a Fontan, which makes it technically more challenging. So you really do need a surgeon who is very skilled in this process. As well as there are additional techniques that we use at Boston Children's, things like EP mapping in the operating room to identify the conduction system. And then also our intensive care unit is very well versed on how to take care of these children after a biventricular repair. But, the biventricular repair is a more complex surgery, and there's definitely, more upfront risk in many cases than a Fontan. But we believe that sometimes that upfront risk is really beneficial in terms of having a better long-term outcome.
That's great. Yeah, I think it's a really important point, Dr. Burkham, that I feel like as we started to do more of the advanced surgeries and surgeries to avoid the Fontan, that we've had to develop some tools along the way to help us. And I think the 3D model is a great example of that. I remember when we started utilizing it and how it made a big difference. We did initially we were doing 3D printing, but now we've sort of transitioned to the models that you've created, which are much more helpful in terms of surgical planning. I think another good example of that is the intraoperative conduction mapping. We can now precisely locate where conduction is to avoid complications such as a pacemaker. And I think even in the cath lab, for example, we're looking at PV loops using something known as a conductance catheter to help us get a better sense of what the ventricular function is. These are all sort of innovations that have enabled us to really do things in a much more advanced fashion and help bring advanced therapies to many of these kids. There was another question in the chat about the hypoplastic right heart. We've been talking about a hypoplastic left heart so far, but just because we didn't really have enough time to spend on both the right and left heart. But needless to say, we also are very interested in thinking about ways to avoid the Fontan for the hypoplastic right heart. A lot of the same considerations go into taking care of patients with hypoplastic right heart. So thank you for asking that. And we certainly believe that for hypoplastic right heart patients, there are patients who could avoid the Fontan. We use a lot of the same technology to kind of help us better understand who is a candidate or not.
I just answered a question in the chat, but there was a question about a child, if a child has hypoplastic left heart syndrome and, is there a potential for a biventricular repair type option? And I just want to kind of emphasize that there are some children with HLHS who are not biventricular repair candidates. So those are the kids who have mitral atresia. So they basically have no mitral valve at all. And in those, or if there's like essentially no visible left ventricle. However, there's a group of kids who have mitral stenosis and aortic stenosis. That means the valves are open and there is blood flowing through the left ventricle, but the left ventricle just might be small and have endocardial fibroelastosis. And in some of those kids, those are the ones that we have been able to do left ventricular recruitment procedures, and we're able to get those left ventricles to grow to some extent such that it's able to do more work, and then we can try to come up with a biventricular type of option for those kids.
Well, that's very true, and I think again, this is not a sort of one size fits all, and I really feel that our process involves shared decision making. We're frequently spending a lot of time on multiple visits to sort of go into depths and into the details of what does it mean. What are the potential benefits and risks of each pathway, and really want to make sure that our families feel comfortable with the decisions being made. Our job, as I see it, is to really offer as many options as possible, and to really think about what is best for that child depending upon their status. And I feel like parents bring to the conversation important information about what your child is like, and I think that that's really important in helping make this decision. So there's obviously the process of evaluating things from an imaging standpoint, but then there's also the most important and the funnest part for me is where you get to meet the child and get a feel for who they are and what the family's goals are, and I think that's really important in terms of making these decisions.
Yeah, and I just want to add a little bit to that. Thank you so much for those comments. But then I also want to add another point about our complex biventricular repair program here at Boston Children's. We really, our entire heart center has been very focused on this population of patients, just because we have a relatively high volume of kids who come through with who are undergoing complex biventricular repairs. So we've developed a lot of collaborations with our other services within the heart center. So for example, our intensive care unit, our advanced cardiac therapies program, our arrhythmia specialists. And we've been developing protocols and ways of managing patients that I feel like gives us a little bit of, an opportunity to really take good care of our kids. And I think that's one thing that makes our center unique. And I don't know if Dr. Amani, you have any other comments to add about that, but I feel like we've kind of been, our goal is to develop really as smooth of a process as we can for our families, and also make sure that we're not leaving any stone unturned in terms of our overall management. So, a lot of our children will need additional medications or, additional thought about, other treatments that may be helpful to them. And so we've really kind of just collaborated with the whole Heart Center on this program.
Yeah, and I think for patients with heterotaxy syndrome, for instance, we have I've been very impressed with our heterotaxy multidisciplinary team that is able to sort of think about not just the cardiac considerations, but the pulmonary and other aspects of care, which I think is very important. And I would just say that if we're taking care of a child with possible option to avoid a Fontan, the earlier we get involved and can help think about the management together, the better it is. And it really allows us to have a comprehensive approach and think together with their local teams. I really want to open things up for a Q&A in the last few minutes of this webinar. Please feel free to enter a question into the chat, and we'll be happy to answer it. And maybe I would ask Naomi to comment a little bit on how we take care of families while they're in the hospital after a procedure, and kind of your involvement or physician assistant involvement in the intensive care unit and the floor. Maybe you can just talk a little bit about that.
Perfect. And one thing I did just want to talk about with all of our collaboration, that collaboration really starts when we first start to review your child. Many of those intensivists are on the call conversations they can join and actually be able to right up front be able to give that opinion to try to help make this process even more seamless. But during the ICU stay, I will frequently visit you, starting at rounding out like 6 in the morning. We'll be able to see how your child is doing first day postoperatively, and I'll be seeing you the entire time that you're there. If it's not myself, then it's one of the other physician assistants that is part of the surgical team. And then once you move on to the step down floor, I'll usually hopefully come up and visit you at that same time too, just to make sure that everything is going smoothly as you go through that process and transition over to our step down unit.
Thank you. There's a question in the chat, maybe Dr. Barucham, I'd direct it towards you. Using 3D MRI reconstructions, and how we're using, are we using AI in a way to kind of help with planning surgical intervention and predicting outcomes? How do we use the 3D MRI, and how many patients have we had so far with 3D MRI, and how we use that information?
Yeah, I mean, we typically do 3D MRI reconstructions on everybody, either MRI or CT, where it just gives us this kind of three-dimensional picture of the heart. Currently we have not been using AI to plan the surgical intervention to predict outcomes, but certainly that's something for the future. The issue really is that when you're using AI type techniques, you really need to have a more homogeneous population, like a group of patients who are kind of similar. We currently still have fairly wide dispersion in terms of the type of anatomy and diagnosis that our kids have. A lot of these surgeries are just planned for individually. I'm a very strong believer that we have to look at the individual child and not just their heart. There's also other things about their cardiac history or their medical history that are really important in terms of making decisions. Yeah.
Right. There's another question about endocardial fibrolastosis. Is it present in every patient with a hypoplastic ventricle, or only certain types? Dr. Barucham?
So endocardial fibrolastosis, I just want to explain what that is. So, Dr. Amani showed it in that video earlier, but it's this sort of kind of almost like a scar tissue layer on the inner surface of the left ventricle. And what usually causes endocardial fibrolastosis to occur is if you have fetal aortic stenosis. So if during fetal development, the aortic valve becomes too small, the left ventricle is trying to pump blood out that aortic valve and it just can't get the blood through. And what happens is that this it just gets really highly pressurized. And that causes this level of scar tissue to develop on the inner surface of the ventricle. And then what happens is that scar tissue prevents the ventricle from relaxing, and then it's not able to grow. And that's what causes hypoplastic left heart syndrome, actually. So EFE is very, integral to the development of HLHS specifically. But EFE is not expected with all hypoplastic ventricles. It's only the ones that have an intact ventricular septum, or the ones that don't have a ventricular septal defect. So it's typically the HLHS patients who have mitral and aortic stenosis or something like that.
Right. So if a child has a diagnosis of unbalanced AV canal defect with a hypoplastic ventricle or transposition or a ventricular septal defect, they're unlikely to have endocardial fibroelastosis. And we usually detect the EFE by MRI. So it's pretty easy to find out if they have it, if there's any question whatsoever.
Yeah, and the EFE resection that is done during surgery is, what it allows the ventricle to do is just relax better, and that helps the ventricle to be able to grow and provide a higher stroke volume and do more work. Most kids with EFE don't end up with a fully normal left ventricle after the recruitment procedure. And so actually, I just want to emphasize a little bit about this left ventricular recruitment procedure, that it is a way of us not only trying to get that ventricle to grow, but it allows us to test the ability of the ventricle to pump blood. And so we can measure after this recruitment procedure, we come back, we repeat an MRI, and we can measure how much the ventricle is pumping. We can do things like pressure volume loops in the cath lab, which help us understand how well that ventricle can relax and what it will be able to do if it's being asked to provide more flow. And that helps us make decisions about, what biventricular kind of options we have at the end of recruitment. And if there is no option, then, we have not burned bridges for a Fontan. And in fact, we actually believe that recruiting a left ventricle may make a Fontan circulation even better, just given that the left ventricle is doing more work overall.
Thank you. There's another question in the chat. Maybe I'll answer this. How long do the individual surgeries take? Great question. Depends upon the type of surgery. A recruitment procedure in which we're closing just the atrial septal defect with a fenestration to promote flow into the left side of the heart is probably overall about 4 to 5 hour operation. With everything entailed. A full biventricular repair where we're doing complex reconstructions can take 8 to 10 hours sometimes. So it really depends upon how complex the procedure is, and it can vary. But needless to say, we have developed strategies to be able to take on very complex procedures. In fact, we're probably doing 1 or 2 complex biventricular repairs a week, and that really means that our teams are very comfortable with doing these types of surgeries. And so we find that it is that even though it seems like a really long time to be in surgery, that at the end of the day, what's really important is that we have a good circulation, and that creates a good outcome at the end. There's another question in the chat about how long does the recovery in the ICU typically take after a biventricular repair? Naomi, maybe I'll let you answer that.
I think it can be also a little bit variable of how long the ICU stay is, but if I can kind of give you an idea of what our ICU looks like, is that in general, there's also a sequencing space for parents so that one of the parents can always stay with your child. And kind of how the structure of the ICU works is that we typically do surgical rounds early in the morning, 5:45 to 6:30. Then you'll have a team round that you'll be able to participate with your ICU attendings. You'll have a nurse practitioner, and your nurses will all be able to kind of go over the care in general and exactly tell you some of the benchmarks that they're expecting for your child within the next 24 to 48 hours. So it will kind of be like a day-by-day process, but they'll give you benchmarks that they're hoping to attain within that time. And then you always are going to have someone who is taking care of your child from the surgical perspective. There are NPs and PAs that are going to be in the unit for us. And then you always have your ICU staff that is there 24/7.
I kind of feel like some of the recovery, there is an early adaptation phase for the biventricular repair that can take a couple of days. We tend to go a little bit slowly with, making sure the circulation is good, making sure that everything is working well. And then once we get past that early phase of usually the first, 3 to 5 days, then the recovery is much quicker. So my sense is that we tend to go very carefully and cautiously in the beginning, and then later it really things move along pretty quickly. But the ICU stay can be anywhere between 2 days to sometimes up to a week, depending upon how the child responds. And we really want to pay close attention to how the circulation is behaving and make sure that that the child is ready to really move on to the next step. We have an intensive care unit staff that are dedicated to the complex biventricular repair program that pay close attention and kind of watch out for kids. So there's really a big team around it, as you said, Naomi, and I think that's really important to have. And so along the same line, is the recovery different for ventricular recruitment versus a biventricular repair? I think the ventricular recruitment is somewhat of a smaller surgery, and part of the reason for doing things in steps is to avoid having to all of a sudden create a large load on the ventricle, and to really to do it all at once. And I think the ventricular recruitment allows us to sort of do a gradual loading of the ventricle, which ultimately leads to a better outcome. So yeah, I would say that the recovery, especially in the hospital, is generally shorter for the ventricular recruitment procedures.
So we have another question. If we do the Norwood locally after birth, when is the best time to come out to BCH or involve BCH? So, we've brought some children after a Norwood. So at the time of their Glenn is when we consider doing the left ventricular recruitment procedure. And then we've had other kids who've already had their Glenn who have come out for left ventricular recruitment. Dr. Amani, what's your preference? Like if you were to meet a family kind of in the neonatal period, what would you recommend to sort of start that recruitment process?
Yeah, I would like to know about the child as soon as we're starting to think about the long term, even if the Norwood is done locally, because we sort of plan the approach. We might get a sense of what imaging is necessary and when, and it really allows us to have some lead time to think about it. So I like to have these conversations well ahead of time so that we're not doing things in the last minute. So the earlier we can start talking about it, the better. But I agree that the Norwood can be done locally, and then come to BCH at the time of recruitment at around 4 to 6 months of age to start the recruitment process. And I think that works reasonably well as well.
I just want to add a little bit to that. So, obviously this interstage time between the Norwood and the Glenn is a critical time where a lot of children are being monitored by home monitoring programs, and we want to make sure that a child is safe. So if a Norwood is done after birth and we're kind of getting close to the time when the child's oxygen levels are beginning to drop down and they really need to have their Glenn procedure done, I do want to avoid traveling across the country to come to Boston when a child might get sick. And so, the timing is actually we have to be cautious about it. And in some situations, the Glenn circulation is a little bit more of a stable circulation. So some kids will have their Glenn locally and then come to us later.
Yeah, again, the earlier we can find out about, we can, not everything needs to be done in Boston. We can help sort of decide which procedures or which imaging needs to be done in Boston versus what can be done locally. We understand that it's tough to come to Boston for everything, and we understand that. We also have a really strong support team. A shout out to our coordinator staff who are behind the scenes, kind of making sure that families get supported with housing and trying to make sure that we can schedule things in a way that's convenient for family members to be able to take time off and come here and really make things efficient with all of the visits and the testing. So we try to do that, and I know, Naomi, you're also involved with trying to make sure that a lot of that is taken care of.
Yeah, I think our coordinators do an excellent job really looking at how they can best help each family and giving them a good sense of what it's like to be here in Boston and how you're going to spend your time in the ICU. So they really do a great job.
Another question in the chat about pulmonary artery banding and whether that is an option, and if pulmonary artery banding is recommended, when does that occur? So there are certain types of conditions for which a pulmonary artery band is an option rather than doing a Norwood or a stage 1 palliation. It really depends upon the anatomy. And so that's again another individualized decision that's made. But if we do have a condition that requires a pulmonary artery band, I typically will recommend having that done within the first few months after birth. But it really does depend upon the physiology, and if there's a need for a band, sometimes the band needs to be placed shortly after birth. And so we certainly will help make that decision based upon the clinical picture. And before we end, because we are getting to the last few minutes of the webinar, I wanted to say that we have a bunch of we may have more questions, and feel free to reach out to the program. We've put into the chat the contact information for our complex biventricular repair program. In addition to that, this recording will be added to the BCH YouTube page, as well as our website. So feel free to share information about the webinar with others, and certainly I really thank you for joining the webinar today. And if there are any other questions, feel free to reach out. And any closing remarks, Dr. Brukim or Naomi?
No, I mean, I just want to emphasize that, we have a group that we work really well together. We're happy to, our goal is to sort of try to help people. So we're happy to review, do the second opinion process and really give you information about your child. A lot of this stuff has to be made individually.
Yeah, and during our second opinion process, I think it's really robust conversation to try to give the best options possible with a lot of different providers to give input.
Great. Well, I've also I wanted to thank both of you for being part of this, and looking forward to sharing more information. There are probably more webinars coming in the future. We hope to use this as a way to sort of help educate and open up for questions. So again, thank you very much for joining, and we look forward to seeing you all again soon.